The title of the presentation is The History of the Endovascular Revolution. This was really a revolution. Not the kind of revolution we have in South America. This was a good revolution. This is my disclosure. I don't need to speak about John Thomas because we had already his history. It was famous, and we pay tribute to him. I did several developments in vascular surgery. 4 of them are FDA approved: endograft, flow reversal for protection device, endosutures. I am a co-founder of Aptus, and I developed a coaxial guide wire that is going to come to the market soon. And this year we celebrate the 25th anniversary of the first successful endoluminal treatment of abdominal aortic aneurysm. As you know, aneurysms are the 5th leading cause of death in men over 60 years. It's an increased incidence and prevalence. It's an estimated 2.5 million AAAs in USA. We know a lot, but we ignore a lot about this. I'm not going to go through this, but we know that there is a destructive remodeling of the elastic media, overproduction of connective tissue proteinases, chronic transmural inflammation, and apoptosis of the smooth muscle cells of the media. When we study the wall of the aneurysm, we see the destruction of the elastin and collagen, at the same time an upregulation on MMP9 and MMP2. I should say that most of what we do today in vascular surgery is different of what we learned in our training. Minimally invasive procedures are a new part of the armamentarium of vascular surgery. Vascular surgeons embraced minimally invasive procedure very early and had to make an effort of learning these new techniques. I remember John Porter when he said, "We will never learn how to use wires and catheters," and we had to do it. Had they remained exclusively committed to open surgery, vascular surgery would not be alive today. Cardiac surgeons did that, and as a consequence, they are doing much less minimally procedures than vascular surgery. EVAR was the wake-up call for most of the vascular surgeons. Iliac artery and SFA stenting are commonplace now. We also do carotid, subclavian, visceral stenting, and you name it. The arguments against EVAR were instrumental in prompting new and improved devices. As you can see, what happened since the year 2000 to 2010, thanks to our effort, is that vascular surgeons are now the leaders in doing peripheral vascular interventions. Fenestrations and branch endograft extended further the practice. In TVAR allow us to cover aneurysm dissections and trauma of the aorta. We are growing old, and at the present rate, the average American can expect to undergo 7 operations during his or her lifetime. So we need to think about introducing minimally invasive procedures for us, because we will need them. The concept was different in the past, as you can see this quote of William Hunter. He said, "Anatomy is the basis of surgery. It informs the head, guides the hand, and familiarizes the heart to a kind of necessary inhumanity." Probably the first one who thought about minimally invasive was Ambroise Paré, who was a military surgeon, who said that the surgeon sometimes made more harm than the weapons. And I was trained under the premise that the greater the surgeon, the bigger the incision. And the Pope Francis still tells me, "I remember you every day when I take a shower because the incision I had here in my belly." We can say that probably minimally invasive vascular surgery started with the angiogram from Dos Santos. Forsman performed the first cardiac catheterization. Seldinger, his technique. Fogarty, our great friend, introduced his catheter and opened the door for endoluminal therapy. Daughter, his coaxial dilatation. grown sick, his percutaneous angioplasty. Our friend Palmas introduced the balloon expandable stent, and we and others the endografts. Tim Shooter went beyond this and started in 2005 with fenestrated endografts. The first durable treatment, as you know, started in Paris with the Boss. We used a homograph. Then Boris in New York introduced a synthetic graft. Surgery, what we do today and we used to do in the past, is durable, effective, but it's a big operation, no question. It represents a big trauma for sometimes old and debilitated patients. One day I was a resident and we had 2 consecutive bad outcomes after AAA repair. And at the same time I was being trained to do Seldinger technique. And I told Alfred Humphreys, who was my boss, Al, I think we can do a Seldinger technique with a bigger catheter, introduce a graft, compressed graft, and a metal component to replace the suture. The name stent was not given at that time, so I used the name cage, a metal cage with barbs. So we wanted to have a less invasive, less morbid, less lethal, and equally effective. And entering from the groin. So the conception was that in 1976. And we did the first prototypes in the engineering department of the Cleveland Clinic using elastic wires of stainless steel. And this is the first prototype we developed in 1976, and used in dogs. In 1979, I presented the first protocol to treat type B aortic dissections after seeing a patient ended with paraplegia, just to cover the entry side with this cylinder covered metal I developed. But Toby Cosgrove rejected the project and didn't get any support from that. We started at that time the experiment using with the device I already showed. Then I met Julio Palmas, and I thought perhaps his stent is better than mine, and I started to use his stent. I redesigned his stent in order to go up to 30 millimeters, and I started to use that in animals in 1987. In 1990, I had a phone call from the president of Argentina. He told me, my Secret Service told me that you are doing something new for aneurysms. My cousin has an aneurysm and a back pain, and he has severe COPD, so please do it. So he came, and his family came. I explained the procedure, showed the angiograms before and after, and they say, you have a lot of experience. And I told them, hold it, those are dogs. You're going to be the first human. But I can tell you that since 1976 to 1990, 14 years, we didn't receive any funding, any grant, any support from anybody. So we were using our own money for this development. So we were chasing dogs on the streets, and today we cannot do that. But at that time, Buenos Aires was plenty of dogs. So we had a pentothal and syringe, and we were chasing them. So we were taking them to the hospital, and I had permission from the director to replace the aorta with a graft with the shape of an aneurysm. And after a few months, we were ready to put this endograft inside. And you can see we were following these patients. We were placing these dogs in one of my friends' farm, and we did 53 dogs, and we followed them for 6 months. Finally, my institution gave me the permission to do 50 cases, and the condition was that they had to be rejected at least from 2 well-known centers. This is a patient who had 10 abdominal operations and ileostomy at 2 open hearts. So we have surgeons, we have a simple mind. So the first device was simple. It was a graft I designed with expandable ends, the extra large Palmas stent, a sheath, the Teflon sheath with a valve, a wire, and I took from the cardiologist the valvuloplasty balloon. And this was the initial idea to do aortic, and this was the first patient, done in September 7, 1990. I have a video of a case done a few months afterwards. I don't think it's worthwhile to see this. But no question that the incision was much smaller than the incision we used before. I think at that time we created a hybrid new specialty. We had to learn, in spite of what John Porter said, to use catheter, wires, stents, and other products. And so we did the first case in September 7, 1990. I invited Julio Palmas, who assisted me, and at the same time, the following case was an open case. Then we had dinner, and after dinner, we went back to see our patients. And the patient who had the endoluminal treatment on the local was having dinner, and the other one was still intubated. And Julio told me, if we can prove that we can repeat this, and this is durable, we are going to make a revolution. And this was the first publication that I owe John Bergen that supported me to publish this in the Annals of Vascular Surgery, the initial 5 cases. But complete happiness doesn't exist. In a few months, we started to see failures. And the failures were related to the aortic system because the distal neck sometimes is non-existent or very, very short. So we were having leaks in the distal part. So we decided to do a bifurcated graft. We did it. We put the stents. The angiogram looked beautiful, but unfortunately, the base success was -23, and the patient had massive microembolization. So the excessive instrumentation caused the first fatal complication. As you can imagine, I was very disappointed. I stopped the project, but in a few months, we restarted with high-risk patients doing uniiliac grafts, occluding the contralateral limb with detachable balloons initially and with the cover stents afterwards. So this is a homemade extra large Palmas, and we were cutting one of the legs, and it was very primitive. But even being very primitive, it worked. So when we had lack of distal aortic neck, we did the uniiliac. When we had narrow external iliac arteries, we put a temporary conduit using a 10-millimeter Dacron graft. And when we had aneurysms of the iliacs, we coil-embolized the hypogastric, or most of the cases, we did an anastomosis between the external iliac artery and the hypogastric artery. We did the first case in Europe in 1992, the first in America on November 1992 with my good friend Frank and Michael Marin, and the dream was there. So what I told Alfred Humphreys that I was foreseeing a day in which the patient was walking into the operating room, and we were doing the case under local anesthesia, percutaneously, putting a Band-Aid, and the patient was walking home the same day. As a matter of fact, we do ambulatory surgery in 1/3 of our patients today. Obviously, we can use this for aneurysm dissection, trauma, and occlusive disease. As I said, team developed the endograft with branches. We started to use this 5 years ago. I'm going to show you a small, very, very small video of a case done under local anesthesia in a patient who was 86 and had a thoracoabdominal aneurysm. We did this from the groin under local. And this is the T-branch that was developed by Tim. And it's a graft with branches on the sides. We were extending this to the abdominal aorta. This patient had a ruptured aneurysm before and was treated surgically 10 years before for us. And you can see, you place this very easily, and then you start cannulating the branches and just placing stents, cover stents. We will use the fluency stent and a self-expandable stent inside. We do this routinely, as in many places in the States and in Europe. And without any question, according to the Cleveland Clinic reports, this is durable and is going to probably replace open surgery in the future. This is the left renal, and then we'll cannulate the SMA. All done on the local. The patient was alert, patient with severe comorbidities, local anesthesia. So that was our dream. This is the SMA. And this, after 4 years, you can see the aneurysm disappeared and all the branches were open. Roy Greenberg, my great friend, developed the helicoidal hypogastric branch and cooked the straight. There were many people thinking in the same way we were. The only difference was that we were persistent. We had no money, nobody supported us, but we were convinced that that was the way to go. So many people tried to do the same thing. The only difference with us, we are not more intelligent, but we are more persistent. I also pay tribute to my good friends, Tim Schroeder and Roy Greenberg, because I think they went beyond this and developed something that is going to cover the whole aorta, including aortic valve. And this is the face of my professor in Buenos Aires when someone asked him about my behavior. You see his expression. But he was one of my best friends. And I quote Giles when he said, since the introduction of EVAR, the annual number of deaths from intact and ruptured aneurysms has significantly decreased, and this coincided with an increase in intact AAA repair and a decrease in ruptured aneurysm diagnosis and repair volume. As a matter of fact, I think a great indication is emerging in this ruptured aneurysm. And Ben Starnes today has 16% mortality rate in all comers, including pararenal aneurysms. This is durable. Even the initial primitive device, this is a 20-year follow-up in a patient I did in Europe. They sent me the CT scan. And we see patients for many, many years, and the balloon expandable stent doesn't migrate, doesn't produce any leak. One day I'm going to explain to you why we don't have it in the market. There is a big reason for that. Also in 1990, we started to use endograft for dissection. This is a patient I received from the French hospital who had a stroke 1 month before and a growing aneurysm, and he had a dissection of the abdominal aorta. And this 1 year afterwards, you can see that the tear was covered with the cover stent and the patient was alive. And that was reported also in the Annals of Vascular Surgery as one of the 5 cases. So this was the first endograft used for dissection in 1990. Trauma was a great indication. We used this routinely in patients with gunshots. I was taking care of the father of the general of the Pentagon in Buenos Aires, and the same day we had a case of this gunshot, and he invited me to come to the Pentagon. And I presented 50 cases of gunshot wounds treated endoluminally. The other thing I started and I developed was the endosuture. We saw initially migrations and leaks. So I came with the idea of creating a suture, and we developed this. And today it's called Aptus, and it's very useful for some situations. But the evolution, as you can see very easily, that the number of EVARs in 2001 was 11,000, and 2010, 50,000. The number of open procedures decreased, and there is a steady decline in aneurysm rupture and related mortality. The global aortic market estimated is $1.7 billion in 2014. This is a very interesting data from the US Census Bureau. There were 101,978 patients in the national inpatient sample affected by AAA in 11 years. Overall, in-hospital mortality was 7%, with a median length of stay of 5 days and hospital charges 58. EVAR was associated with lower in-hospital mortality rate, 4 versus 1% for non-rupture, and 41 versus 27 for rupture. Shorter median LOS, but a 27 to 36% increase in hospital charges. The overall use of EVAR has risen sharply in the past 10 years, 5.2 to 74. And the most important thing that in-hospital mortality rates for both rupture and unruptured cases have fallen by more than 50% during this time period. We still have problems. That's why our journey still continues. We still have problems that we are solving progressively, and we are very optimistic. We are doing better every day. We still have problems with patients with large neck aneurysms, cases outside IFU, type 2 endoleaks, and ruptures. Initially, the ruptures were a big concern. Today is much less, but we still have to follow our patients. For instance, patients with large infrarenal necks, they have 12% type 1 endoleaks. One of the solutions for this is the use of endosutures. And there is a publication that endosuture prevents the endoleaks in patients with large necks. Outside IFU cases, everybody is using this, and we know that we have more secondary procedures, but the survival is similar to the other cases. In some reports, they say has no impact on outcomes. In this one, no difference. We use several resources to our outside FIU. Extra large format stent, endosutures, flexible endografts, the orthofix, fenestrations, this is a great step forward. Chimeneys, steerable endograft is going to come shortly from Gore, and open surgery as a last resort. Type 2 endoleaks, we are solving this problem. My group and the group of WashU, where I worked for many years, have wonderful results, as you can see, that the patient had no recurrence after embolization, translumbar embolization, or transarterial inferior mesenteric artery embolization. Conclusion, EVAR has lower perioperative morbidity and mortality. Survival advantage over open repair lasted for 1 to 3 years in the different trials. In older patients, the survival benefit is higher, but if you see the curves, there is an overall survival benefit in EVAR. They live more, no question, that we prolong life for all undebilitated patients. The mortality, as you know, in the trials are completely different. The quality of life is less impaired, recovery time is more rapid. Secondary procedures related to aneurysms are more frequent in EVAR, but most are minor and catheter-based. The increase in secondary procedures in EVAR is counterbalanced by the higher incidence of laparotomy-related procedures, which are more frequent in open repair. Graft complications occur in EVAR even during the late follow-up, and obligated for lifelong surveillance. Safe and effective today, almost 80% of the cases are done endolumina, and with the introduction of fenestration, indication will expand further. Weaver believes that this is a disruptive technology. I don't know if this is an insult or a virtue, but no question that this is different than what we were doing before. And the poor Albert Einstein that died because of rupture aneurysm had this famous formula, and we tried to adapt our thoughts to his formula that endovascular is my choice too. And the guys from the American College were very kind and they published a booklet, and they included us in 100 years of surgical quality improvement with the endograft development. Thank you for your attention.
Thanks very much, Dr. Perotti, for both being a great leader in innovation and keeping vascular surgeons at the forefront of vascular disease management. You've been a tremendous credit to our profession, to our society, and we're very honored to have you here today. And in recognition of that, we'd like to give you a Hohmann's plaque as a distinguished lecturer. I know you have a long trip back to Argentina, but there aren't many people who have this plaque, so please keep it carefully in your seat or above you and hold it in your office in Argentina. So congratulations again on a great talk.
Thank you.
You want to hold this? Nice, great job.